Hi, I'm Karen Bodnar, and I have been involved with Academy of Breastfeeding Medicine for quite some time. I am currently serving as a member of the board. I'm also on the board of the North American Board of Breastfeeding and Lactation Medicine, and I run a breastfeeding and lactation medicine clinic in Northern Virginia. I also do a breastfeeding medicine podcast and webinar with the Institute for the Advancement of Breastfeeding and Lactation Education. I'm really excited to be talking about anatomy and physiology of lactation. I actually really love this topic because it's so important into what we do to take care of patients. When I was in medical school, I remember learning very little about breast anatomy besides the location and what lymph nodes cancer would spread to if people got breast cancer. And then I had my own kids, and I realized that when I was pumping, milk was coming out of more than one hole, and I was shocked. I really felt like I hadn't learned anything at all. And so I got more involved, and I learned a lot. Really, the structure of the breast is so important to the way that babies and parents work together with breastfeeding. And I think that, the very simple idea that there are multiple lobes in the breast, there are all these tiny little structures that are sort of a little bit like grapes on a vine, where the vine would be the part running through the nipple and areola, and then the grapes are all of the alveoli in the breast, helps us to understand how milk is produced and travels down and is extracted by the baby. And there's actually been not a lot of research. There's not a full understanding of everything we need to know. There's been debate for years. Are there milk duct sinuses, sort of the end of the duct? Does it swell like when the original anatomists injected paraffin wax into there? Or is it not like that? Breast surgeons are like, I don't see any big sinuses. And now we're starting to understand that really it's more of a potential space. It's like an ambu bag. When the milk is being ejected from the breast under the influence of hormones, those ducts swell up so that when babies compress the tissue, the milk sprays out. And I think that really helps us to understand when a section of the breast isn't draining well, what's going on. Inside the breast, there are all of these tiny little structures, the alveoli, and they're kind of pointed all different directions, which can make it hard for the breast to empty effectively when they're swelling. And that's something that happens a lot in the early postpartum period. We know that early in development of, in the embryo and even in puberty, there are these little buds, but the full formation of the gland doesn't happen until pregnancy, and then milk can be produced after a delivery. The individual alveoli have wrapped around their basement membrane these myoepithelial cells, which respond to oxytocin and contract and help the milk to move down to where the infant or a pump can extract it. During pregnancy, the prolactin starts to go up higher, and the withdrawal of the hormones of the placenta after delivery allows that to really act on the breast. And that's when we get the transition from colostrum, the small volume that's needed for the baby in the first few days, to larger volumes of milk. At that time, we also have learned that the tight junctions between the lactocytes are closing, and that causes the sodium to drop before the increase in milk production when the lactose increases. And now we're able to use that understanding in science to help us better understand when people are going through lactogenesis too. It's not just, does this patient feel an increase in fullness? We can really understand the science behind it to identify, for instance, parents who have babies in the NICU who are struggling with milk production. What is the cause of their challenge? Is it more of a hormonal problem or more of a structural problem? And then we can get them help. We know that during pregnancy, prolactin is going up, up, up to help the breast to grow. And then the nipple stimulation that comes from baby suckling is what is going to lead for that repeated spike of prolactin that tells the breast, make more over the first few months. And it's really important because people who don't have frequent nipple stimulation don't have prolactin that is at levels that is going to cause their milk production to increase. When we think about people who are choosing not to breastfeed or are really ill and are unable to initiate, their prolactin goes back to non-lactating levels by 2 weeks postpartum. And that is why weaning naturally occurs if people don't have that frequent stimulation. that's information that parents need to know, because we can't, unfortunately, just breastfeed during the day and give babies bottles of formula at night. It's not the way our bodies evolved to work. Also, we know that the level of prolactin doesn't directly lead to a certain level of milk. There's a lot of variation. And so there's a lot more research that needs to be done around this, but people need that early nipple stimulation. They also need to have really effective milk removal. Oxytocin is the other hormone that plays a big role, because when we are feeding a baby, or we hear them or we see them, our pituitary releases this hormone that causes all of those alveoli to be squeezed by those little muscle cells and have the milk come down. And I think there are a lot of misconceptions about how milk is removed, and I think it's really helpful to understand that babies are not working really hard to remove milk from the breast. They have evolved to sort of sleep most of the time and drink when it's easy. And I like to tell parents it's a feature, not a bug, that they sleep all day long. And when they're on and that suckling causes oxytocin to be released and milk is flowing like a waterfall, they drink really easily. Recently, one of my friends said to me, it's kind of like when you're in the airport bathroom and you're waving your hand by the sink with the sensor and you're like, come on, come on. And then the water starts to go. That's what babies are doing when they're on the breast and they're nibbling and they're waiting. And then when they're slow, they drink for a few minutes. Of course, the thing shuts off before you've finished washing your hands. The babies fall asleep, and then they try again in a few minutes. They get the rest. One of the big things that interferes is engorgement. And going back to, when I had my first kids, I was like, oh, this is amazing. My breasts are getting bigger. I have a lot of milk. I didn't really understand there is sort of a breast milk compartment in the breast, and then there's a second space that is separate where any fluid that has leaked out of the tubes or alveoli goes, any edema, and that takes up space in the breast, and it can actually compress the ducts in the nipple where the milk is supposed to exit and make it really hard for people to get out milk. And it can be really confusing to families. They think they don't have any, when really they're just having trouble with removal because of that swelling. And this is because there's a lot of edema in between all of the tubes. And when milk leaks out into those spaces, it is never going back into the tubes to come out the nipple. It has to be removed in the way that edema gets out of our ankles. It finds its way into the lymph nodes and back into our circulation. And that's really important when we're treating people, so that we're not telling them, firmly massage your breast towards your nipple. That isn't going to help in mastitis or any sort of engorgement. Light lymphatic massage toward the axilla is going to be far more effective. Just a couple more things. I will say I also see very frequently people who are pumping who have trauma, because we haven't really done any studies telling us how should flanges fit. And sometimes people are using flanges that are too big, and not only the nipple is going into the tube, but a lot of the areola. And that's problematic, because if too much of it goes down, it really causes swelling that compresses those tubes. And sometimes even the denser glandular tissue that starts where the areola ends meets the back of the tube and can cause sort of a ball valve effect that really stops flow from the pump. People respond by turning up the vacuum. They're really trying hard to get milk for their babies, and that can make the swelling worse, and it can be a vicious cycle. It can be a really hard thing for patients to understand. And so teaching very simple techniques of hand expression on the areola to soften it can make a really big difference, and should be first line in early days before pumping. And lastly, I think that it's really interesting to think about what is a normal amount of milk production. I really love this picture that a patient allowed me to take for teaching that shows what happens when somebody is breastfeeding on one side and they've weaned on the other side. This patient had a 9-month-old who really had stopped taking one side many months before, and so her one breast thought she had twins, because that breast was doing 2 breasts worth of work and the other side had stopped. And it's fascinating in that really many, even pediatricians, don't understand what milk volumes are needed for different sizes of babies, and that really it's the baby's weight in combination with the age that tells us how much they need in the total 24 hours, and that most babies peak their milk intake by the time they are 5-ish kilos, and then they take the same amount of milk, usually every day from about 3 months until their birthday. And that means that while people are needing to increase milk in the early months, then they're stable. And I meet a lot of parents who are like, oh, how am I going to keep making more milk at 6 months and more milk at 9 months? And they don't know that's not necessary. So really, we can often help people, even if they're giving some formula in the early days, or even half and half, to get back to making enough breast milk for their babies with great support and understanding. So all of the things we learned about anatomy and physiology can help us to take great care of patients. And I hope that this was helpful. Thanks. Have a great day.